Good morning and afternoon, depending on where you are joining us from today. We're delighted to share this time with you. We welcome everyone to the Inner CFAR Faith and Spirituality Research Collaborative webinar entitled Medical Mistrust at the Intersection of HIV and COVID-19, Breaking Down Barriers Through Science and Faith. I am one of the co-moderators, Dr. Dilara Uskup, a postdoctoral fellow at Charles Drew University and a project director at the UCLA Center for HIV Identification, Prevention, Treatment Services. I am delighted to be joined by Louis Shackelford, the External Relations Project Manager at the COVID-19 Prevention Network and the HIV Vaccine Trials Network, who will be co-moderating this presentation today. Before we move forward, we do just want to share a little bit of housekeeping that for technical issues or for Q&A as our panel begins to engage this really robust discussion, we invite participants to submit questions at any point in the YouTube comment feature and also on our Facebook page, and we will be certain to incorporate those questions and comments throughout the webinar this morning. We do want to open with a moment of silence, honoring the lives of all those who passed due to COVID-19 and to HIV/AIDS. We thank you so much for that solemn moment of silence. And now we will be joined by Dr. Burley, who will be leading us in a prayer and meditation this morning and afternoon.
Thank you. Let us pray. God of life, whom we know and love by many names, we pray before you in this second year of a COVID-19 pandemic and in this 40th year of an HIV and AIDS epidemic. And yet and still we pray before you, thanking you for your rahmah, thanking you for your peace, thanking you for your love. We are especially grateful today for the ways in which you've allowed us to stay together, even when COVID-19 has driven us apart. And we give thanks for this moment and these experts that have given of themselves and of their time to share and be able to connect the science that you gave us to give us life with the faith that you gave us to sustain us. Please bless those who have lost life, bless those who continue to fight for their life, and bless those who have assembled for this event to provide information that sustains life. We give you thanks and we give you praise. Amen, Amen, Ashe.
Thank you so much, Dr. Burley, for that beautiful prayer. And at this time, we would like to introduce our panelists who will be joining us this morning. And we just heard from Dr. Ulysses Burley, the founder of UB The Cure, LLC, and a former member of the Committee of the World Council of Churches, the U.S. Presidential Advisory Council of HIV/AIDS, also known as the PACHA, and the Faith Community Engagement Ambassador of the COVID-19 Prevention Network, the CoVPN. So delighted to have you joining us, Dr. Burley. Thank you. Next, we'll be introducing Dr. Marina Bruce, who is a professor and the Director of Faculty Development, Director of the Program of Research on Faith, Justice, and Health in the Department of Population Health Science at the John D. Bower School of Population Health at the University of Mississippi Medical Center. We also are joined this morning by Khadija Abdullah, the founder and executive director of RAMA, the founder of the National Faith HIV/AIDS Awareness Day in the District of Columbia Center for AIDS Research. And we're also joined by Dr. Michael Sagg, the Associate Dean for Global Health, the Jim Straley, Chair in the AIDS Research Center, and the Director of the UAB Center for AIDS Research, a Professor of Medicine at the University of Alabama at Birmingham. And we also invite our panelists to briefly introduce themselves this morning or afternoon. Don't all jump in at once.
I feel like you kind of covered it already, Delara. Like you said who we are, where we're from. I don't know what else to add to that. I'm based here in DC, as you mentioned, and I really got passionate about this field when I was in college when I met a Muslim man living with AIDS, and also when my friends became positive. So it kind of opened my eyes to the necessary work around HIV and AIDS education. And then also I'm a part of the COVID-19 prevention network and working with faith communities to kind of talk about COVID-19 and the vaccines and mistrust and how we can come together to address these issues and hopefully provide comfort and support as we try to fight this COVID-19 virus and survive out here in these streets. So.
Well, I'll go ahead. Again, it's an honor and a privilege to be here. And I'd say good morning, good afternoon, hopefully not good night to some folks out there. I'm Marino Bruce. I appreciate the warm introduction. I certainly appreciated the prayer. And the only thing I would add to that is that I am one who seeks to be a bridge between the scientific community and the faith community. And that means that taking both seriously. I think one of the key things that I've seen in the work that I've been doing over the past couple of decades is that one-sided approach does not get us anywhere. We have to lock arms and march together, use our skills, understand our lanes, but understand that we're going to the same destination. So I'm always honored to be part of discussions like this because we all learn and we all can take something back. And I look forward to doing that today.
Thank you. Again, my name is Ulysses Burley, and I'm the founder of You Be the Cure, which is an organization that operates at the intersection of faith, health, and human rights, where we treat people and not just disease. I also serve as a faith initiative ambassador with the COVID-19 Prevention Network and have worked with my sister Khadijah and others on the founding of National Faith HIV and AIDS Awareness Day. So I'm very happy to be here.
And hi, I'm Mike Sagg. I'm at the University of Alabama at Birmingham and director of our Center for AIDS Research. I've been involved in research and treatment in HIV since the mid-1980s. And early on, we brought the faith community into our clinics, and it's been a really wonderful interaction and collaboration that I think has really helped an enormous number of people. I had COVID myself almost a year ago on Friday the 13th. I became infected back last March, and fortunately I've recovered from that. But that there's an intersection between these pandemics of HIV and COVID that go beyond just people who happen to have HIV who develop COVID. There's a lot of similarities that I think we'll be exploring today. So I really look forward to it. Thanks for including me.
Thank you. Thank you to all of our panelists. And I do just want to share that you can post your comments or questions in the comments section. Prior to beginning our discussion this morning or afternoon, I would like to share our objectives for today. And the first objective is to gain an understanding of medical mistrust, to share ideas on bringing together the faith and science community in addressing medical mistrust, and to think about how faith-based initiatives can help bolster vaccine education, uptake, and distribution, and to address health inequities among people of color, and to disseminate information about the COVID VPN and the co-VPN faith initiative. And I think we also have I think there was one other slide that kind of demonstrated our overview. If we can pop that back up. Fantastic. And as you can see here, that this is our overview. And during this webinar, the panel will discuss the faith community's response to the COVID-19 pandemic and the HIV epidemic and address medical mistrust in communities of color and how it contributes to health outcomes, and share ideas again on breaking down barriers through science and faith. And that's really what we want to emphasize together today, this partnership between science and faith and how we can break down these barriers in medical mistrust. So I do invite all of our panelists back to our studio, and we begin with our first question. I will be leading the first half of the webinar, and then Lewis will be taking over, and then we'll be going back and forth. Thank you. So let's go to our first question. All right, how can the faith community support vaccine rollout?
Well, I guess I can begin by saying, first and foremost, we've been preaching the 3 W's throughout the last year. Wash your hands, watch your distance, and wear your mask. But I think one of the W's that is especially important for the faith community that we can add to that list is to continue to worship virtually, right? And so, over the last year, we've learned that God is still with us, even in our homes and even on Zoom and even over the phone. And despite some of the mandates that have loosened around the country to allow some people in some places to re-enter their houses of worship, I think we have a responsibility as communities of faith to continue to consider worshiping remotely until our country has achieved herd immunity as a whole. And so I think that's one very easy and doable thing that faith communities can do to support vaccine rollout. I think another thing they can do, which is also centered around our buildings, our houses of worship, is to make their houses of worship available as vaccine distribution centers. And so I know that's already beginning to happen all over the country. I read a report just today that the largest Black church in Aurora, Illinois, which is a suburb of Chicago, was going to be one of the newly minted vaccine distribution centers. And I know the National Council of Churches, which is the collection of Christian denominations in the United States, is also working very closely with the Biden-Harris administration to coordinate with member Christian churches around vaccine distribution sites. As a person of faith, as a person of African descent, I know in my African descent neighborhoods that there are more churches than there are pharmacies or healthcare centers. And so why not leverage that presence and converting those spaces into spaces where people can access healthcare and in this sense, the vaccine. So I think those are very two easy and doable things that faith communities can do right away to support vaccine rollout.
I think another thing that faith communities can do is to really focus on information dissemination. We're going to talk about this later, I'm sure, but there is a lot of mistrust. I'm hearing things like, this was done so fast, weren't corners cut? I don't understand how this vaccine works. Will this interfere with my cells? Will it get into my DNA? There's a lot of information that's just partially out there. And unfortunately, social media, while it can be wonderful in many ways, it also can be a place where people get misinformation. So I think the church communities of all sorts can help disseminate a clear message about what the vaccine is and what it does. And to that second point, what does it do? I think one of the things that we can focus on is the truly miraculous nature of this vaccine and its timing. The one way to focus on it is to say, what would have happened if the vaccine had failed? Pause for a minute and just think about that. We likely wouldn't be seeing the decreased number of cases that we have in the last 6 weeks. We would have continued with the epidemic, but worse, continued with the epidemic with no clear end in sight. What happens if our current state back in December, January, we're just going to be perpetuated over months and months and months? And so I look at what happened in December with the release of the wonderful news about the vaccines as a true miracle in our lifetime. We read the Bible, we read religious texts, we hear about miracles. This was one that happened to us just 2 months ago, in my opinion. And so celebrate that Christmas miracle of 2020, and let's disseminate the goodness from that, the information from that, and that's our pathway, that's our exit out of this horrible pandemic.
Thank you, Dr. Sack. I do just want to ask a follow-up question. What would we say, and I want to open this up to all of the panelists, to a faith leader who is uncertain and who is hesitant, who does raise those points about, we're coroner's cut, or is this vaccine going to get in my DNA, and expressing both medical mistrust, but then also may not have full clarity around actually the science of the vaccine. So what might we say to that a faith leader who is uncertain and hesitant?
Well, I want to hear what others have to say, but my thought immediately is to provide information to the clergy, to not just clergy, but lay leadership in the churches and synagogues and mosques as well, that knowing what the true facts are is the first step. And so we, in the scientific community and those who have been involved in the research, I think we need to make ourselves widely available to folks to get the proper, correct information out.
And to add to that, I was going to mention back to the first question, where I mentioned how that, your faith place can become a space to actually do vaccine rollout. So where I'm based at here in Northern Virginia, my faith, the masjid I go to, they also run a health clinic, and they made it a vaccine rollout space. And I see people of all faiths going there to get their vaccines, including my mom. She went there, and we went there, so people all different backgrounds getting the vaccine there. So that's one way a faith community can support the vaccine rollout. And then number two, I know people have questions about the vaccine. Is it okay for us to take it, as you mentioned, Delaria? Or, some people will ask, does faith support taking vaccines? Like, what's in the vaccine, and is halal, or is it okay for me to take it? And I think if folks have these questions, they can invite folks like from the COVID-19 Prevention Network to kind of come out and do like educational webinars or provide resources to the community so they can understand what's in the vaccine, what's going on. If they have questions around mistrust or, medical mistreatment, we can kind of provide a space to talk about it and really answer their concerns. And I really would encourage faith leaders that if they don't know something, it's okay not to know something, but it's also very harmful to give out misinformation, because it can really harm, someone's life. So if you don't know the answer to something, a lot of times faith leaders aren't doctors, they aren't public health professionals. So it's good to kind of collaborate and partner with those who are, to really support your community. And also another thing you can do in the faith community is do interfaith collaborations or partnerships, because we're all in this together. And if your mosque or your church can't provide a vaccine space, but that your friend, in Tempo is, you can send your congregants there to get their vaccine and have that partnership and create that safe space. So that's my my input.
Absolutely.
So I'd like to add to both of the questions. I think one of the things that when we say faith community, the first thing we have to do is understand the heterogeneity within it. And so for example, if we're even looking at Christian, we're not even going across other faith systems, but understanding that there's a heterogeneity within Christians. And so understanding that the belief systems that exist may not be all that aligned to scientific communication, but understand those who are, and begin to start where you are, understanding who is an important partner, but also understand the networks that they represent and who they're connected to. That's important. So it's really important to understand how faith communities sort of work, operate, communicate. It's really important to understand that, but also from the faith community's perspective, it's important to be at the table. Not always wait for someone to come to you, but it's important that we encourage them to be a part of state, local, community solutions, as opposed to waiting to be asked to be there. I think we're in a moment now where it's important that we all lock arms and do what we can in this effort to mitigate the virus. On the second part, what would you say to a faith leader who is uncertain and hesitant, is get a sense of what is causing the discomfort. Is it indeed the vaccine itself? Is it, getting a sense of how it works, sort of taking the time to get to know what the individual concerns are and address those accordingly, taking the time to do so. It's important that we just talk, find common language, and then go from there and build on that. If we have folks in our respective churches or congregations who are part of the medical community, bring those folks out front to be a bridge between the two. Oftentimes what happens in moments like this, we try to come into spaces and we bring strangers together. We need to bring together friends to make new friends and build relationships going forward.
Thank you so much. And I am informed that there is a question that has come in live from YouTube. And the question is, with the anti-vaccine statement regarding Johnson & Johnson vaccine from the USCCB and echoed by evangelical groups, what advice does the panel have regarding the conflation of vaccine hesitancy with so-called abortion issues? Wow, this is a powerful question. And I believe the Pope actually had a comment about this not that long ago, but we would love to hear from the panel on this very poignant question from one of our audience members on YouTube.
And if I can just, for those who may not know, the USCCB is the United Conference of Catholic Bishops.
Thank you, Louis.
So, I mean, what I would say this is getting to a point that I made reference to is we got to understand the faith system and belief system before we can try to attempt to get a sense of what issues are being conflated, but also understand the system of beliefs that are there so we can begin to talk in a way so we're not fighting each other. We're not taking a stance of this is right and you're wrong. That doesn't get anywhere. What is the point of conflict? So I'm seeing the conflation here, the word conflation to me saying that, okay, we're talking about vaccines and then we have issues of abortion. Well, in my mind, those two things don't necessarily go together in the same space, but they're obviously something operating here. Let's get at that. And so we can begin to have a conversation and be clear what we're talking about. When we mush things together, that's where trouble begins. Let's be clear. So if we're talking about vaccine, let's keep the focus on vaccine and then ask, well, okay, what is this other concern? How is it, can you make it clear to me how those two things are brought in the same space?
My understanding of the issue of not the hesitancy, but the abortion issues relates to a long time ago, not with this vaccine specifically. The fetal tissue was used in research that led to development of some of the technology and the adenovirus growth that was used years ago. That happened a long time ago. The actual development of this vaccine did not involve fetal tissue. It involved an adenovirus. That's a specific virus. It's a human virus. It's called adenovirus 26. It's not active. It doesn't cause an active infection. It's just simply a vector, meaning it's a piece of DNA that you can put the spike protein portion of the coronavirus in so that it can then be presenting that coronavirus spike protein to the immune system in order to educate the immune system on how to respond to coronavirus if and when it comes into contact with it. So there was no fetal tissue involved in the development directly of the J&J vaccine. And I think that type of information will help, calm this down and have everybody slow it down and move forward with the bigger picture of we need to protect ourselves, our communities, our entire population against this horrible thing.
Dr. Stagg, thank you so much for jumping in, and thank you both for answering that question. I do want to ask, how can researchers support COVID-19 vaccine education within faith communities? And let's say, for instance, there are some researchers in the area, in a particular community or in a city or in a state, and perhaps they may not have existing relationships with faith communities in their local area. How might they be able to support these efforts to ensure that people in faith communities are getting accurate information and able to make informed decisions?
In a phrase, be available. Put ourselves, researchers, a lot of my colleagues are out there right now saying, call me, email me, I'm happy to chat. I love the suggestion of using a member of a given congregation, especially if they're trained in medicine, if they're trained in nursing, or if they're trained as a researcher. They should be, in my opinion, they will be the most effective communicators to that congregation, as opposed, as it was said, bringing a stranger in. But the stranger, if you will, the researcher, can at least be a source of information, ask questions, to be available to set the record straight when there's confusion.
Here,
yeah, go ahead, please.
I'd like to also add to say that, there's infrastructure within the research community to facilitate this support system. And so the COVID-19 Prevention Network, for example, is a research institution that has invested in a faith initiative to empower faith leaders with biomedical information from the very top, right? And so that infrastructure is in place. And those of us, in addition to my sister Khadijah, who are faith initiative ambassadors, are well equipped to speak to both the belief systems and the context for which those belief systems inform how people relate to science and medicine and public health. And in those areas where we aren't able to speak to it, the COVID-19 Prevention Network has made available a speakers bureau that is diverse, that has cultural competency to be able to speak to these issues for very specific demographics, especially those demographics that have been most disproportionately impacted by COVID-19. And we've been able to engage, thousands of people as a result of this infrastructure since, last August. And we continue to do that work connecting virtually, almost exclusively. And for those points where we aren't able to meet the need of a particular community, there is a process for which we can identify persons who are. And so, some of those bridges have already been formed, and sometimes it's just a matter of, letting people know that that bridge exists, and then letting them know how they can access it.
Dr. Burley, quick question. Now, this infrastructure, this information, the Speakers Bureau, this sounds fantastic. How much does it cost a community, a faith community, to bring in someone from that Speakers Bureau?
$0. In fact,
$0.
$0. In fact, we actually have in place infrastructure to actually compensate some of the clergy, some of the faith institutions that we actually engage for doing the work of organizing their people, understanding that we're in the midst of a global pandemic, that everybody is suffering in one way or another. And so it really is an elegant model for engaging communities, where communities are empowered, communities are a part of the decision-making, communities are at the table about science and medicine that impacts them directly.
Thank you for sharing that. Yes, Khadijah.
If I may, I want to add also, research can support by being patient. There is a lot of deep mistrust in communities, and you might have to talk to people more than once or twice or thrice. So make sure you have that patience and really talk to people, help address their fears if they have that, or their questions, because approach is everything. And sometimes if you have a really hard or strong approach, it can turn people away from what you're trying to work with them on. So having patience, like for example, we had, like for the vaccine trial, some people would come in to become part of it. And, I had to take them 2 or 3 times to come in to learn and understand what's going on. So yeah, I'm like, sorry, it's like on the full screen on the sudden. So I think just having that patience is a really good thing, and make sure you really provide in-depth information and answers to those who have questions so they can find some kind of relief or make their own informed decisions about, the COVID-19 vaccine.
Thank you, Khadijah. And I have been informed, and we will be posting these links for folks to be able to click on. But the website is, and it's going across that ticker at the bottom, preventcovid.org. Again, preventcovid.org. And you can also look up the COVID VPN Faith Initiative. Thank you. All right, so we have talked a little bit about how the faith community can dismantle medical mistrust and misinformation, and some actionable items and steps that the community can take part in. I do want to open up and maybe kind of almost open up to narrow down onto this question of what is your perspective of the narrative of vaccine hesitancy among Black communities? So we've been seeing quite a bit in the news. I know I read the LA Times, and I've been seeing quite a bit in there about vaccine hesitancy among Black communities, and this kind of media narrative that has taken shape. So I'm wanting to hear from our panelists about their perspective on this narrative in the media.
Can I say, before we begin a conversation about medical mistrust, I think that it's important for us to differentiate between distrust and mistrust, right? Because they're always or sometimes used interchangeably. Whereas distrust is this lack of trust or confidence or a feeling that someone or something is not being honest. It's sometimes also framed as a suspicion, whereas mistrust is a valid response to a betrayal or having been betrayed. And so I think that's important in terms of the context when we talk about medical mistrust and the mistrust that exists today among Black communities, in the sense that mistrust is the result of a previous action of untrustworthiness, right, of betrayal. And that betrayal is valid from a historical context as it relates to people of color. And I think we have to own that, and we have to name that and not dismiss that, so that we can be able to move forward to show ways in which the system that currently exists is more trustworthy than the system of old.
I'd like to add to that just a bit. A friendly amendment to that is, I think language is important, and so the whole idea of, what is the source of the lack of trust, right? And so I think what's happening in the larger media is that it's using a term, but using it broadly and missing the nuance and contours that are important. Some of this comes out of basically how folks experience the medical system. So again, when we talk about vaccine hesitancy, it's about, well, this treatment of sorts that's being delivered by the agents who have mistreated me before. So how is it that I'm coming to trust this? So sometimes it's not even about the science behind the vaccine. It's about who's delivering the vaccine, right? So and this gets to the important point of knowing the communities, not necessarily not everyone knowing someone in it, but knowing that there's tremendous variation among them, and being patient, as one of the panelists is saying, to get a sense of, all right, what's going on here. I want to get back to this point of hesitancy though. The idea of hesitancy, sometimes that could be overblown. Sometimes it's an idea. For example, I'm in Mississippi right now, in the state of Mississippi, where it's not necessarily hesitancy is the problem. It's just straight up access. So in some cases, what is defined as hesitancy is lack of availability, and we need to understand the difference between those as well. And so, if you look at the data, it may show that people of color are not taking vaccine. Some of it has to do with the vaccines not available to them where they are. So we have to begin to unpack some of this stuff so that when we go into various communities, we actually know what some of the issues are. Yes, there's an issue of hesitancy in some circles, but understanding the source of that. In others, it may not be. So one size doesn't necessarily fit all. So we have to go in with a more with our eyes open and expect to have more of a nuanced, contoured approach to it.
I remember that Dr. Burley and I actually did an event last week where we had an imam on. He said the same thing you said, Dr. Bruce. He said that his community wants to get vaccines, but they can't get to it. And it's like it's like they're being set up for failure. Like, you want to get vaccinated, you want us to be healthy, and we're educated about it, we're informed about it, but then we can't get it. So like, what is this? So that's definitely a main concern. They're in New York, where is like one of the epicenters of the COVID-19 outbreak. So like, they really want. He's seen so many people pass away. He's been trying to get to hospitals. He's buried so many different people. So he's been working, trying to get information out, so we can provide all the education we want to the community. But we can't get them access to the vaccines. There's more that has to be done. So.
Yeah, I love this part of the discussion because it's breaking things down nicely. What I suspect is going to happen is that as far as access goes, that's going to be solved in the next 2 months. I think by mid-May, most people who really want a vaccine will have access to it, certainly by June. And what we're going to find, I think, is a transition from a supply problem to a demand problem. The majority, if not everyone, who wants a vaccine by, let's say, early summer will have gotten it. But that isn't going to be the necessary number of population who have been vaccinated to get to true herd immunity. So there's going to be those who do have some degree of hesitancy, not access, but true hesitancy. Then there's people who are just flat out that just will never take the vaccine. And I think we're going to need to start turning our focus more to those people who are hesitant, maybe softly resistant to it, and start doing outreach. And this transcends any specific community. This will be the whole country, and we'll have plans on how to do that. But of the principles we've been talking about, I love the distinction between distrust and mistrust. That's a really important distinction. We got to fix the access first and then move into that.
One last thing, they also said people would come from the suburbs to the inner cities to get the vaccines as well. So that's also another thing we have to think about, and also getting like a lack of access to getting vaccines. People are coming from other places to get it first, and then the community there is not getting it. So I wanted to add that in as well.
Yes, thank you for sharing that, Khadijah. I do see every day I'm waking up and reading the LA Times, and there are these cases of persons going from outside of the city into the heart of South Central to get vaccinated and stand in line, and that is an issue that we're certainly seeing here. I think, Dr. Sack, were you going to jump back in?
No,
Okay.
one of the things I was going to add to, it's important that we address some of these issues, because again, that leads to the mistrust, right? So if communities are targeted, and let's think about this, if the communities are targeted and they're hearing that vaccine is coming, but folks are coming from outside of that community to get vaccine, people remember that. They remember that. And so again, that goes in the pile of the things that have happened that leads to mistrust. Okay. And so while we, sort of document that, we have to, it's incumbent upon those who have some authority over this. It's important for the scientists and the researchers who are aware of these types of things to, if they get wind of it, use their networks to advocate, hey, we got to stop this, because again, yes, this is COVID-19. We got to fight COVID-19. There will be some other public health issue coming up. And if we continue to do this, we're just adding logs on a fire. So when the next thing that comes along, the degree of mistrust is actually heightened, because people will remember how they were treated during this event. And so we have to be mindful of those types of things.
Thank you, Dr. Bruce. Memory is certainly important, and collective memory is tremendously important. We do want to jump on into an audience question that we received from Sarah George, and that question reads, if we want to approach a religious leader who disagrees with the information about the vaccine, how should we move forward? Have you faced any community leaders like this? So we want to invite our panelists to join in on this question. Again, a religious leader who disagrees about information about the vaccine, and how to move forward, and share strategies and experiences from the field if you may have them.
I think Dr. Burley addressed it a little bit earlier, but to start with trying to understand what the nature of the problem is. So I wouldn't start by walking in with a series of facts and a slideshow. I'd sit there and go, tell me what you're thinking. Listen, truly listen, and understand what the issues are. Don't interrupt. Don't propose solutions. Get the whole story. Follow up with more questions before any solutions are created or given. Engage. By listening, then we can start building trust that at least some information I might be giving is trustworthy because I'm not forcing it, and I'm really trying to understand truly what that person is thinking. I think that's the most important principle as we move forward in talking to anyone about these vaccines.
Yeah, absolutely. And, I think there's also this concept of not only is the message important, but the messenger is important, right? And that's very much at play here too. And so, for example, if Dr. Sag went into a historically Black congregation and delivered the exact same factual information about COVID-19 and the vaccines being developed for it, it likely would not be received the same way as if I went into that historically Black church and delivered the exact same information. And that's cultural, right? That's how we've been socialized. And so, but it's important, and we have to be aware of that. And so, it's not just the message, but it's also the messenger. And then, if the messenger isn't good enough, we have to come to a realization that some people are determined to be disagreeable, and those people exist. And I have encountered those persons to where the message is right, the messenger is right, and yet and still it isn't enough for people to have faith in the process for which vaccines have been developed and for which they're being distributed. And I think we have to live with the fact that we've done what we could do, and that everybody won't necessarily buy in to the process. And you hope that eventually they'll come along. And one of the things I've seen just in the general population is fear of missing out is a real thing. And a lot of people have shifted from a place of hesitancy to acceptance for the mere fact that the persons around them are beginning to shift also. And peer pressure is a real live and living force. And so, I'm hopeful that, even as we continue to have people who are determined to disagree just to disagree, that fear of missing out will eventually shift their position as well.
Yeah, the one thing I'd like to add to that, I totally agree, is understanding the limits of religious leaders. Okay. And again, I'm not saying that to be disparaging because I'm one of those folks. However, you don't, the way I would think about it is you continue to approach them, right? But you also continue to make sure that you hit those networks of the congregations as well, because some folk in the congregation will want to. They will want access. So one of the things we have to be careful of is you don't necessarily treat the whole church or the whole congregation the way you treat the religious leader of that congregation. You want to make sure that, those networks, the schools, for example, the schools that the kids, that the schools where the children of the church attend, it's available there. In family members, people are influenced by a number of different folks, including the pastor, the priest, bishop, whoever. If the bishop is resistant or the pastor is resistant, you understand, you continue to work on them. However, you make sure that those resources are available in that general community for those congregants who want it now can get it. And I agree that, peer pressure is something else. But also what people see is if I see that someone else did okay with it, then my hesitancy, if I have it, will also decrease. Sometimes I think we overemphasize one individual of a given congregation and ignore the entire congregation. We just got to build around it. That's the concept of herd immunity, right? That we build around so that those who may not be inoculated, they will not be the source for the larger population.
Yeah, I alluded earlier when I did my introduction about how I've been working with churches for HIV for really it's 30 years, maybe a little longer now. I learned a couple of lessons early that play into what we're talking about. First thing I learned is that religious leaders oftentimes are on annual contracts. And if they go too far, they don't get their contract renewed. And that's a very real thing. So being controversial or being out there is not to their advantage, which led to the second lesson is when we did AIDS education for churches, we always included the clergy leader, but we really focused on the lay leadership of that congregation to be in the meeting because that was our audience. The clergy can't do anything unless the lay leadership is in lockstep with them. So that's going to be important here. And to also underscore, I gave a lot of, I won't call them sermons, but let's just call participated, gave talks during Sunday services in a lot of churches in the Black community. I was warmly welcomed, but I think the point is there was a barrier because I wasn't really a member of the church and they listened politely, but I'm not sure that my message was well received just because who is this guy popping in here and telling us this? I would hear it better if it came from somebody I was more familiar with. That's absolutely true.
Great. And I want to thank all the doctors for those great responses. I've come out with some hashtags from this group, hashtag vaccine FOMO, hashtag building barriers or breaking barriers. So, and there was one other hashtag that I think that was Dr. Bruce that just came. What was around the herd immunity hashtag? That a hashtag emerged for that from me. What was? Can you repeat that line back for me one more time about building?
You build around them. It's the same
build
concept.
Around.
You build around. Yes, you build a network around.
Build around. There we go. All right. So we are delighted to bring on Lewis, who will continue this very, very robust discussion with our panelists. And we want to continue to thank all of those who are joining in our audience and continue to thank those who are asking questions and engaging.
Thank you so much, Delora. I mean, this is an outstanding conversation we're having. And Dr. Sag, I just wanted to go back to something that you mentioned. You got us started on how the HIV work that you all have been doing for many, many years, and you all have been doing outstanding work. That's why you're here. How has the work you've done in HIV informed the work that you're doing now in COVID-19? We know that these are two different epidemics, but are there any parallels that we can draw to move us forward in?
Yeah, I'm glad you asked that. The answer could be 30 minutes, but I'll bring it down. There are tremendous similarities. Scientifically, just the notion of how a vaccine is approached, how do you use the genome of the virus to identify the key areas that can be amplified like we've done with the COVID vaccine and then developed into an actual vaccine product and tested. The actual testing approaches, the methodology was directly lifted from years of HIV vaccine research. So the science I could go on for days to talk about, but just there are a lot of lessons learned and a lot of foundation that was built through the AIDS epidemic. But on a more human personal level, when I became infected with HIV, with COVID, I reached back in my memory bank to the 1980s and taking care of patients who developed advanced AIDS for which we had no treatment. And I was dealing with COVID. I got pretty sick, and I knew that feeling from watching my patients go through it. And it's a terrible feeling to have something that you don't have control over. You don't know minute to minute whether I was going to get sicker and go to the hospital or whether I was going to make it through the night. And I've grounded myself there on a very personal level. But the other thing is the lessons I learned from my patients, besides just mustering up the courage to face the day-to-day illness, is to go public with my story. And I immediately did that. I did Washington Post interviews and a number of other media outlets talking while I was in isolation, while I was sick. I talked to our Rotary Club in Birmingham about what it was like for me, just to make this people know that this was real. And I think finally, as we're talking about now, the lessons that we learned from working with faith communities has really helped us, at least, begin to breach that. As a lot of you know, we have full-time clergy in our clinic. Reverend Hamlin has been with us for over 20 years now. He was a former pastor at the 16th Street Baptist Church here in Birmingham, very known, well-respected, and helps us with outreach into the community and is engaged now with COVID outreach as well. And our whole community and behavioral science core that is following up on this. So too many lessons to be mentioned in this short amount of time, but it is fundamentally similar, and the lessons learned apply almost directly.
Thank you, Dr. Sag. Anyone else like to weigh in on how their work in COVID and HIV has informed the work that they're doing now in COVID-19?
Yeah, I can absolutely say that my work around HIV and faith communities has helped to prepare me for work around COVID-19 and faith communities. Especially since both carry a level of stigma, right, that we've had to address. Both diseases have disproportionately impacted Black and Brown people, and both epidemics have been made worse as a result of the social determinants of health. And so the networks that I was able to engage and have been able to engage over the last decade around HIV and faith communities are the same networks that I was able to tap directly into to engage around COVID-19. And it really helped give me a head start in terms of being able to, make an impact to give people the information that they need, so that when vaccines became available, a large amount of folks had already been reached as a result of this relationship that existed between us, a relationship of trust, no less, regarding HIV. I think also we have to just name that all of the foremost researchers and scientists around the world that are working on COVID-19 are generally HIV and AIDS practitioners and experts.
Mm-hmm.
That's benefited the rapid response to COVID, but we have to make sure that it does not come at the expense of the gains that we've made in the HIV and AIDS pandemic, and the promises that we need to keep for the next decade for people who are currently living with HIV. So it's absolutely helped to inform the current work that we're doing, and I'm intent on using that information to remind people that HIV is still the deadliest pandemic of our generation, and that we have to make sure we honor that in its 40th year since its identification, and continue to combat COVID-19. And some of the things that we can do in the terms of addressing the social determinants of health, in terms of addressing the ways in which stigma and discrimination make people sick, and how that intersects with people's belief systems. The work that we do for HIV will also benefit the work that we do for COVID moving forward. So we have to be able to, it's a both and not an either or right now approach. And I know I and my colleagues are committed to both right now.
The one thing I'll add to that very quickly is thinking where the early work that I did in HIV work was working with churches in terms of trying to help them understand what it was, particularly in rural areas. That's where I did a lot of the bulk of my work there. And one of the key things that helped me was thinking about this not only as a scientist, but also as a theologian, in terms of trying to figure out, okay, what are the messages that I have to help them see. One of the key things goes back to, am I my brothers and sisters keeper? And what does that really mean? And hammering on that, you know what, we're dealing with, regardless of what you may think, these folks are dealing with something serious. This is somebody's brother, this is somebody's sister, this is somebody's parent, this is someone's child. Dealing with that, the base level of humanity, is critically important. And so doing that work then has stuck with me and actually led me to the work that I'm doing now, which is thinking about how it is that we have to maintain these bridges between the scientific community and the health community, because yes, it's been 40 years of work in the HIV/AIDS world, and now people are leveraging the lessons learned from that to approach COVID, which means that, as the scriptures will say, there's nothing new under the sun. What's important is that we have to learn the lessons to whatever event we have and apply them moving forward, because there will be another time where we'll have to do that. And so we cannot forget. We cannot forget that that we need each other as we walk through this. We need to learn how to talk with each other. We have to build trust. A lot of the talk now is, when we have a health issue, we worry about issues of distrust and mistrust, and we forget about building trust. How is it that we build trust from this moment forward, so when the next thing comes along, we can build on those relationships and then begin to mitigate it?
Awesome. Powerful thoughts all around. Any other comments before we move on? Okay. Dr. Burley mentioned something that stuck with me. And he mentioned how there is this parallel between the stigma that he's seen in the HIV world doing this work and stigma in the COVID-19 space. So can we just take some time to expand upon that? What stigma are we seeing around COVID-19, and how does it parallel the stigma that we've seen in the HIV space? Because we know stigma has been a crucial factor in why some communities have been really ravaged by HIV. And so addressing stigma has been a constant battle in our work in the HIV space. So I want to see what's the parallel of stigma in COVID-19, and are there any opportunities for us to address that? Dr. Burley, I guess I can start with, go ahead.
Yeah, I was going to say something that Dr. Burley was saying earlier. It speaks to this idea of where I see stigma is a way of elevating one and putting someone else down. And we see that, and we've seen that in terms of what people have defined as essential workers, right? They're saying essential workers, but they're at the back of the line when it comes to vaccine. We're okay with them coming into the grocery store and stocking shelves. We're okay with them going out in the fields and picking our food, but we're not okay with them, getting vaccines first. So part of this is one of the things we have to watch is how we value people. How is it one group is seen as more valuable than the other, and how do we treat, quote unquote, the other? That's one of the things that I've seen that's been uncovered, or one of the parallels is that we've somehow found ways to devalue one group or value one group more than the other, as opposed to saying, you know what, again, going back to that theme, am I my brothers or sisters keeper? Meaning that they are human just like me, but somehow we find ways to separate as opposed to bring together.
Yeah, I would say from a historical timeline standpoint, with the identification of HIV in the States, it was largely among white men and coastal metropolises. and there was a sense of urgency around HIV and AIDS in terms of social activism and advocacy. And when a shift began to take place to where the majority of people being impacted by HIV were largely poor Black and brown people and sexual and gender minorities, then the social activism and advocacy began to wane. And I saw a similar trend in much short order at the beginning of the pandemic when we didn't have data, and at the beginning of the COVID-19 pandemic when we didn't have data, and states were poorly reporting race and ethnicity numbers as it related to cases, hospitalizations, and deaths. And as we got out of April and started to get into May, we started to see some of that data come into focus. And those of us who knew the work, who have done this work, especially around HIV and AIDS, already knew what the data was going to suggest, but it confirmed that Black and brown people were being disproportionately impacted by COVID-19. And all of a sudden, you start to see mandates loosen all around the country, and restrictions lessening, as a result of this response. And, and again, it was I feel, a direct response to having information that suggests that, oh, it's these people who have been most impacted by COVID-19, and therefore we don't necessarily need to sound the alarm as hard as we've been sounding the alarm. And so I think that that's one parallel that has existed. One of the obvious parallels is the discrimination and the heightened violence against people of Asian descent, right? Especially when we have political leaders who continue to call COVID-19, the China virus, right? That's a stigma, and it's a stigma that has unfairly put a certain group of people at danger, as a result of it. And so we still see that stigma manifesting today. And then I think finally, there's the stigma of poverty, right? We punish people for being poor every day in this country. And Dr. Brand talked about it. Essential workers were, for all intents and purposes, expendable workers, right? Essential was just a euphemism for expendable. And so we continue to ask people to go out and to serve our needs. People who didn't have insurance, people who couldn't take off of work and quarantine and adhere to stay-at-home orders, people who could not afford childcare so that their children could be safe while they were able to work. And those are the people who have most been impacted by COVID-19, and they are poor people. They're people who don't benefit from salaries, and people who have the corporate safety nets that exist for those who have different socioeconomic statuses. And we see that in the data today in terms of the people who continue to be, twice as likely to be hospitalized, or 3 times as likely to be hospitalized, and twice as likely to die from COVID-19 infection. So definitely have been parallels. I always say that if the HIV epidemic, if half of the people living with HIV and half of the new infections of HIV in this country were among white people, we wouldn't be entering into the 40th year of HIV. And I think I still stand by that.
Powerful words. Powerful words. Any other comments?
I feel like everyone said everything. Like, I had different ideas in my head and they're all touched upon. But just to reiterate again, I think a lot of it has to do with racism and race. Like I said, I talked with people on the ground, and some of them have been part of, working against addressing HIV stigma since the 80s, since it began. And they're seeing some of the same patterns happen now, especially in our Black and brown communities. And even so, when someone mentioned hospitals, some people are being turned away. We hear many, many stories of Black women and Black men and how they're being turned away from hospitals and from people of different backgrounds and races. So it's the same things. It's a continuous cycle over and over and over again. And the question is, how can we stop it? And we know how we can stop it, but when will it stop? I mean, we have the answers, but when will we actually put these answers into play and actually take action to, make it equal for everyone. Like, will that ever happen in this country? And, then we had the Black Lives Matter movement. I mean, that, has been amplified this past summer and into this year. And then, we have people who claim to be allies that were out there with us, doing these rallies. And then once the cameras went away, they were gone. So it's like, are you really supporting the Black community and brown communities? Or are you just doing it when people are watching? And is that sustainable? And no, it's not. So it's just my thoughts.
Go ahead.
Sorry.
No, go ahead, Dr. Strack.
About stigma, when you get into the weeds on it a little bit, I think it's pretty much divided into external and internalized stigma. So we've been talking a lot about external, where somebody literally is projecting there are consequences of discrimination. Internalized stigma is a whole nother entity, and especially to play with HIV, but it's to play with COVID as well. And that's kind of the feeling that someone has that other people are judging them or might be judging them, even when that judgment may not be active. And that interferes with accessing care, that interferes with accessing help. And the way it plays out in COVID is that people might start developing symptoms that sound pretty much like COVID, but no testing is done because they don't want to deal with it, because they may feel like other people are going to say, well, you got this because you didn't follow the mask rule, or you didn't do what you were told to do. And that delay in getting tested and therefore getting access to some treatments like monoclonal antibody, which could be life-saving, gets delayed. And so that's another type of stigma that's at play that I thought I'd mention.
I think that's an excellent point, which gets back to the hesitancy piece, right? I don't even want to engage this right now, right? Because of it gets to the hesitancy piece, it gets to the mistrust and all of that. So again, in terms of, we have this event that's happening, and there are lessons that we need to learn, that we need to build on. And even post-COVID, there will be a post-COVID at some point. But if we just say, okay, we're past this, and we just leave everything the same, then the next health crisis, we're going to do all of this over again. I love the idea of that. Yeah, the external stigma and internalized stigma, it leads to the same thing where folks either they don't feel that they are worthy, or they don't want to be blamed for asking for help, or they don't receive it. Either way, it endangers us all. And so how is it that we move to a point where we recognize and we lean into, we're all in this together? What happens to you happens to me, whether it's today or next week. At some point, it will get us. How is it that we change that narrative? That's the question that I think we're dealing with.
Agreed. In some spaces, I've heard people talk about the harm reduction model that has come out of HIV work specifically, and how that model can be used in these COVID-19 spaces, potentially with folks that are reluctant towards taking a vaccine. Could that harm reduction model be a benefit for faith communities or others who are having issues or have some reluctance in taking the vaccine? Is a harm reduction model a model that can be used in COVID-19 spaces?
I'm not sure if this is what you're talking about, but one thing that I think is effective in talking to people who are hesitant, or especially if they're resistant to hearing messaging about a vaccine, a lot of times what I'll hear is somebody say, I don't want a vaccine. I don't want to deal with it. I'm going to take my chances on getting COVID myself. Is to flip the script a little bit and say, yes, We understand that about you, but what about your mom or your grandma? If you get sick, you bring that home and you could infect them. And while you aren't likely to die because you're a young person, they are at higher risk and they could die. So you don't necessarily have to do it for you, do it for them. And that's an approach. It's not exactly harm reduction, but it is flipping the script a little bit so that it's not just about do this for yourself. It's do it, or even do it for your neighbors, which is what herd immunity is about. Do it for those who mean the most to you.
Absolutely. Ulysses looks like he's thinking really hard.
Yeah, I'm thinking about, how some people would consider harm reduction to be making sure people can safely socialize during COVID-19. I think about harm reduction, especially in the context of HIV, and I think about privacy and accessibility and accommodation. And I'm thinking about one of the models that was just introduced to me in the last week about concierge vaccines, right? And the ability for healthcare workers to go on demand into people's homes and to administer their vaccine so that people can access the solution that they need without necessarily having to engage the outer world and all of the stigma, either external or internal, that comes with it. I think the same way in which, we have made novel in-home and self-testing for HIV and AIDS as, in my view, a form of harm reduction because it allowed people to access medicine and solutions without necessarily having to engage a system that perhaps has historically made them sick or has historically harmed them, right? And so, especially as we talk about for people of color, where we talk about medical mistrust and how it might not necessarily be, to Dr. Brand's point, the vaccine that people are hesitant about. It's the system that's delivering the vaccine that people are hesitant about, right? Whether it's a particular hospital or a particular caregiver. I think when you bring harm reduction to this conversation, there are probably a lot of different interpretations of what that might mean as it relates to COVID, but those are the ways in which it kind of percolates in my mind in terms of getting people the access that they need to the solutions that are available to them without them having to necessarily engage a system that has historically hurt them.
I think that's a great point. And the other, in a related way, is how can we be innovative in this space to do that? Given that we are aware of those things, what are some of the ways in which we can find new ways to help people access the things that they need? Again, for example, testing right now in terms of we've been talking about vaccine because that's been the new thing. But if we go back 6 months, it was all about, can I get a test? How can I get a test? Right. And so at some level, until we reach herd immunity, testing is going to be very, very important. Right. Even when the case, for example, you can have in a household, particularly in some rural areas and some highly urbanized areas, you can have 3 generations in the home. So the one who is elderly or the elder of the family may get vaccinated, but you may have a parent and child, or in that case, their child and their grandchild may take some time. So you still have a level of risk there. And so having access to test and testing to get a sense of the risk or in some cases harm, but at least risk that I run in terms of when I got to go to work, or when my child goes to school, or my child plays sports, or whatever, having access to things like testing where I can get it, it's accessible to me, so I can continue to monitor that, is going to be critically important. It's great that we're going to have these vaccines. It's great that, you know, the deadlines or the dates where it can be available for anybody who wants one, but we still have to work out the kinks to make sure that people get them. And then at some point there'll be a declaration of herd immunity, but what do we do in the meantime? And so that's where the space that we're entering into is that meantime period. What do folks do then? And I think to both Dr. Sag and Dr. Burley's point, are critically important. And that's the next phase that we got to think about, particularly when we're talking about engaging faith communities. That meantime point is going to be very, very important.
Dr. Bruce, you've brought up herd immunity a few times.
Mm-hmm.
Do we want to take a shot at explaining what herd immunity is for our audience and why it's so important, why that may be the end goal?
I will defer to Dr. Sag on that. Because he's in the space. He's in that space. So yeah.
Okay. Let me try to define it. So herd immunity basically means that you shut down the transmission of a virus because it doesn't have enough fuel to continue its business. So let's think about it like a fire. Let's think of a wildfire. We've got a fire that's going and it's got all kinds of tinder wood around it, and it's just going to chew through that. If we find a way, let's say, to dampen, we've somehow put water or fire repellent on the areas that otherwise would be susceptible, so that those areas are now resistant, the fire has less opportunities to continue itself. And ultimately, when you get enough retardant and you get enough area covered, it doesn't have to be everyone or everything. The fire just burns itself out. Mm-hmm. So in the case of herd immunity in a vaccine, when you vaccinate enough people such that the infection routes of going from person A to B to C, now B and C are protected, jumping to D, E, or F is much more difficult. And over time, it just burns out. That's what herd immunity is. Enough people in the population who are resistant to becoming infected and transmitting the virus further. Now, what constitutes herd immunity is different based on every infection, and that depends on how easily the virus is transmissible. So, for example, measles is one of our most infectious viral infections. And for that, you need about 95% of the population vaccinated or protected to shut that down. And we've achieved that with the MMR vaccine. Influenza isn't nearly as transmissible as measles, and it's less transmissible than COVID. So we need about 60% of the population to be vaccinated to really kind of shut that down. COVID, we're looking at about 75% of the population that will need to be vaccinated in order to protect it or shut it down. However, with these new variants that you're hearing of, the UK variant, the Brazilian variant, the California variant, what that does, those viruses are more transmissible. Therefore, the number of people that need to be vaccinated to achieve herd immunity against those variants jumps up to about 80%, maybe 82%. So what we need to do is focus on that. And to also, the final point I'll make is that herd immunity is not a light switch. It's not on or off. It will ease into it. So we're already seeing a reduction in transmission just from the 10% or so of the United States who have been vaccinated. As we get closer to 50, 60%, we will see caseloads coming down just from that. And as we get to 70, 80%, hopefully, then we'll see transmission becoming a relative rare event. And my final point is an adage in infectious diseases is this. A virus isn't gone anywhere until it's eliminated everywhere. So when the US and the Western nations get their act together and get their herd immunity achieved, that's step one. But along the way, we've got to focus on resource poor countries and get vaccines to them and make sure that the virus is suppressed there. Because if we don't, first off, it's a humanitarian issue. It's just, in my opinion, what we should do. But beyond that, if we don't buy into that argument, it's to protect the rest of the nations in the world against churning a virus in a population that's not well protected and emergence of variants, because that emergence is simply survival of the fittest. It's Darwin. It's what we know happens in biology. And then once that happens, then the protection from the vaccines may no longer protect, and you get another wave of a pandemic. So that's the long-winded big picture. Hopefully that was clear.
So let me say this. Thank you, Dr. Zach, for catching that. But also it's important that we know who knows what so we can ask. The point of that was there's no way I could give that response because that's not the area that I'm not an expert in that area. But it's important that we know those experts so we can consult with them. Mm-hmm. And I think that's always important when we often go to religious leaders and sort of give them a bit of information. But if they got that question, can you imagine the fumbling going on with that? Right. Mm-hmm. So we have to be careful and have a comprehensive approach as what Dr. Burley and those resources that he and his colleagues have. We got to make sure that those are available so that we may go by a church and say, hey, we want to tell you about this, but we got to make sure we have a comprehensive, we leave them with something that they can use, because at some point they're going to talk to someone else. And we got to make sure that the information they share with someone else is something that will help someone else and not hurt them just because they don't know how to respond. It's critically important.
And to the issue of building trust, coming back to distrust as opposed to mistrust, trust is built by honesty. And
Indeed.
There's absolutely nothing wrong with saying, I don't know. I don't know the answer to that question. That simple response when you really don't know builds trust. Hey, this person's being straight with me. So never make up an answer, ever, when you aren't sure what that answer is.
And that cuts down on misinformation and disinformation, right? Mm-hmm. By saying, I don't know, that cuts it because I haven't added my 2 cents to it that actually may hurt somebody. Mm-hmm. Saying I don't know stops the harm.
Do no harm.
That's right.
Absolutely. So I noticed that when we talk about faith communities and science coming together, we often focus on the faith community component of it, mm-hmm. And building up those faith leaders, engaging those faith leaders so they can be more responsive to the needs of the community and engaging with the science. But on the other side of it, we have a lot of scientists that may be timid about working with faith communities or may not see the necessary value or inroads in working with faith communities. So what would you all say to scientists to engage them or encourage them to get involved with faith communities and doing this work?
So I'll jump in first on that one because you hit on something that comes a lot in this space, in this work, is that we see the faith community sometimes as so different from what science does that we only see their utility in getting out what science produces. The reality of that is there's so many things that scientists can learn from the faith community. Here's a great example. One of the hardest things you can do out there is behavior change, changing someone's behavior. All right. Religious leaders they identify with that challenge and have thought of creative ways to deal with it. Here's why. If you are in, let's say, a Christian church, a pastor preaches 52 sermons a year. Most of it has to do with behavior change, changing something in someone's life, right? To try to get to another point, another, as we say, optimum life if we want. There are things that they've learned in their walk, particularly those that are seasoned, that can help scientists understand and inform their interventions that they come up with. So there are things that happen in the faith community that science could benefit from if they see the faith community as valuable, in a sense that they can learn from them as well as the faith community learning from scientists. We have to have this mutual agreement here. The faith community is not just a vessel to get out information. It is a community that has strengths, that has assets, that can teach scientists how to do their work better.
Agreed.
Yeah, I would just add to that the importance of data, right? And so they say if you don't have data, then there's no problem. And so part of generating data is, exercising the scientific method and doing this work. And so I think research and scientists are important in terms of helping to produce data around the impacts of belief systems, people's faith in science and in public health and in medicine, right? And so I think the Center for AIDS Research has really done this work well as it relates to HIV and AIDS, and the work around trying to quantify stigma and specifically measuring stigma that might manifest from faith communities, and then using that data to name a problem and then help develop a solution from faith communities and for faith communities. I think scientists are going to be critical in the same way in helping to generate data around the impact of faith, belief systems, and how it is that people access healthcare, how it is that people perceive health and wellness, right? And then that will begin to translate into the viability of the science, right? Because one of the reasons why the COVID-19 Prevention Network's Faith Initiative exists is because scientists understood that it's not about a novel vaccine, it's about vaccination, right? A vaccine is simply a vial on a shelf if you can't actually get it into people's arms. And in order to be able to get people to uptake the science, you have to have some level of relationship with communities, and that namely includes the faith community. If we talk specifically around Black people and people of color, Pew Research says that Black people are the most religious people in the country. And then if you go into that data, it says that Black people, more than any other ethnic group, rely on their faith and their religion to help inform other areas of their life, including health and wellness. And so if we know that, and we know Black people are being disproportionately impacted by COVID-19, then I think it's the responsibility of scientists to engage in that handshake that Dr. Bruce talked about, and to say, listen, we identify a problem, and we know that we have a solution, but it's only a solution if your communities are willing to participate in it. And so let's work together to generate data so that we can both benefit from what's before us.
I have one final thing to say. I know we're out of time, but I'm impressed with our settings that each of us are in. I see Dr. Burley has a ladder going up, probably to heaven. Dr. Bruce has a stairway going down. I don't know where that's going. And I'm sitting here in purgatory. So I got a door, an exit, but I'll
Thank you all for an amazing conversation. We are out of time. Dr. Sag, thank you for your final comments. Any other very brief final comments?
One quick thing. We are our brothers and sisters keeper. And if we can continue to take the spirit of today's conversation and move it forward, we'll be in a better place.
Well said.
Yeah, I'll just say that, we often talk about this dichotomy between faith and science, but as Dr. Bruce alluded to, they are more alike than they are different.
Absolutely.
As both a scientist and a person of faith, I know that science key core tenet is to extend life and life abundantly. Likewise, the core tenet of faith is to promote life, a life well lived and life abundantly. And so I think, in order for us to actually bridge the gap, we have to have language justice in terms of naming both faith and science as one and the same, as opposed to two different things that God didn't give us.
Well said.
I'm just looking for the latter. That's it.
Thank you all for a wonderful conversation. I feel so humbled and privileged to be a part of it. And I'm just really overwhelmed. There's a lot to think about and a lot to contemplate. And that's the way I like to leave these spaces. So I appreciate you all. I appreciate your contributions to this space. And thank you. And, Godspeed and continuing your work. So at this point, I wanted to see if I'd hand it over to our fearless leader, Dr. Robin Dempsey. I think she made us some comments.
Well, and I guess I should say, I don't know where I'm going, with what Dr. Sag was saying. I'm like driving and trying to figure out up, down, around, purgatory, heaven, wherever. But I am definitely in a world of thanks and appreciation for an amazing panel and an amazing discussion. I'm honored to be part of the UAB CFAR, the Center for AIDS Research, and with Eddie Jackson having developed here at UAB the Faith and Spirituality Research Collaborative. And so on behalf of the Inter CFAR Faith and Spirituality Research Collaborative, I'd like to thank the panel, the moderators, and the production team for carrying out this amazing webinar. And as Dr. Bruce said, we are all in this together. Blessed to be part of this team. With special thanks, I'd like to extend to the DC CFAR with George Kerr III and Kenya Hutton, who's behind the scene, just making this all work, and their platform, and Kalani Upshaw for also helping support this production. Our moderators, Delara Yuskop and Lewis Shackelford, always does an amazing job. So thank you for such an enlightening discussion about how we might be able to look into medical mistrust at the intersection of HIV and COVID-19 and breaking down barriers through science and faith. Thank you. And as is up, we have, was up, but we do have a variety of platforms for you guys to be able to, anyone to connect with us. So here through Facebook, Instagram, and Twitter at UAB CFAR BCSC, and our YouTube channel, which we will upload this to at the UAB CFAR Behavioral and Community Sciences Core. So please check it out. Look up information for our next webinar, events, projects related to HIV and COVID-19 research and resources. So thank you again, and we hope you all have a wonderful afternoon.
And one final note for those who are seeking a scientific speaker to speak at their event, they can go to the preventcovid.org website. In the About Us section, there is a speaker request form where you can request a speaker to come and give an educational talk about COVID-19 and COVID-19 vaccines. So thank you all. Have a wonderful day.
All right, thank you.
Wonderful afternoon.